space is two distinct kind of disc spaces in essence, is the superior joint space and then the inferior joint space. And you might think, well, they're just kind of, why do they make such a big deal of this? As we go, it'll make more sense. So this synovial joint between the mandible and cranium. So the great thing about the articular disc is that it's avascular fibrocartilage. And so I'll actually show you some pretty cool videos in a little bit, which will show how high velocity and how much friction happens in this joint. And then you'll see, oh, now I know why it's avascular. Because if there was a strong vascular supply, and the pain sensitivity would be higher. But the fascinating thing is that it's mainly avascular in the central portion of the disc. But the anterior and the posterior portions, there is some increased vascularity, and then so some increased pain sensitivity. And so that's where patients will get. So the idea is that the disc is situated centrally here, things work smoothly. If the disc if the condyle comes anterior, that's where there can be issues. So just real quick, why don't you guys just feel, so your TMJ joints, just so you get an idea. And if you're not sure, just kind of work your way around. Most people are able to find it pretty easily. And if you just start gently opening your mouth, if you're not sure where it is, you'll feel your condyle kind of poke in, and you can feel up and down and around. But if you open your mouth, do you feel your condyle popping into your fingers? And again, you don't have to do it very far. And then do you feel that one condyle pops out quicker than the other? And the majority of people will feel that. And so now what I want you to do is say the word mine, and kind of roll that and how your tongue rests at the roof of your mouth. And now try to keep your tongue up there and open. Does that feel different with where the condyle, how quickly it pops out? Mm-hmm. So that's a common thing that we'll see, because when you put your tongue at the roof of your mouth, this is going to be a really great treatment approach. It allows things to move differently, okay? And this is where the superior joint space and the inferior joint space are going to come into play. So just to introduce you to it, and the example that I'll give is that it is, in some regards, and again, in the class I teach, I again fib a little bit just for simplicity for my patients, but I describe it as a ball and socket joint, and so it truly is. Again, you've got the concavity and the convexity where they're coming together, and so as you open. So again, the way I'll describe it is that it sits here, is as you open, there's a rotation component. And so if that rotation component is happening too soon, if that translation is happening too soon, you could have that joint pop out a little bit. If rotation's happening first, it's not as likely to pop out and cause some of this irritation. So we'll get into more details. I know that didn't make sense yet, but it will later. So then with the articular disc, you have, again, where it sits, you can see a little bit more of that flattened middle portion, and then the more rounded on the outside. And this provides stability for this convex, bony, articular surfaces. So you can imagine if you had a convexity on a convexity, that's not going to be very stable. Does that make sense? So if you look at these two surfaces meeting together, they're not going to be stable. The disc itself is going to provide stability. And you can see, once again, the anterior posterior bands act as wedges, and so that kind of supports and seats the disc. So that inferior disc surface articulates with the convex joint surface, as you can see, as I mentioned earlier, middle zone, avascular, aneural, which is what we want. And then there's one main muscular attachment, which is the lateral pterygoid, which provides stability, and we'll talk more about that later as well. So this condyle relationship, they describe it often as a bucket handle relationship. And so in essence, as the condyle rotates, then the disc is going to go in the opposite direction. So we go back to our previous. So what's going to happen is as the condyle starts rotating, the disc is they're going to go in the opposite directions. And so as that happens, what we want is there actually to be where they come together. Okay, the way I've heard it described, Rockabato would talk about it, is like if you're on a horse and you have a saddle. So is that saddle, you're not going to be very stable unless that saddle is tightened up. And so that tightening of the condyle against that disc, that actually provides stability. And so that's where that bucket handle relationship is. As you rotate the condyle, then the disc is going to go in the opposite direction. So in little things, like I said, this is where it's weird with the OCS exam. It's like some of these little details, you'd be like, seriously, am I supposed to remember this? But some of these concepts, again, if you're thinking about it conceptually, I think you'll understand a little bit more. Just take your time and kind of think anatomy, what's going on. And so what that allows is anterior and posterior rotation of disc. The condyle disc glide in opposite directions in period rotation. So again, if you get a bucket handle idea, so the disc is going to rotate posteriorly as the condyle rotates anteriorly, and then that happens in a reverse direction as one closes their mouth. That's normal anatomy. So I mentioned earlier that the joint is broken into two surfaces. So there's the superior joint, larger, and so it allows the gliding of that joint. And then the inferior joint is more of the hinge joint. And so that allows rotation of the disc on the condyle under the disc. So again, allowing rotation. So this is, if you're gonna if you wanted to make a note, the big thing is rotation happens in the inferior joint space, okay? And translation happens at the superior joint space. So rotation, inferior joint space, translation, superior joint space. And again, when we get into the arthrokinematics, you'll see why that's important, and then how that will lead into dysfunction. Because what if that happens in the reverse way, that's where dysfunction starts happening. So ligaments, functionally, they don't play a major role. Like when I'm treating patients, I'm not typically thinking that much about the ligaments, unless, like any other ligament, when would you think about a ligament coming into play in other joints of the body?
Knee joint, or
So knee joint with what?
any type of traumatic instability.
Exactly. So the only time I'm really thinking about ligaments within the TMJ is if there's been trauma. And so then you can imagine these are sensitive types of situations as well. So I mean, we could all think of, again, a hit to the face. But then there can be other ones where it could be a fall on the chin. So, I mean, I've got scars underneath my chin here from, again, playing college basketball, and we were joking, my wife's like, when I first watched you play, you were always on the floor, because I was a short, scrappy guy, and I was always diving for loose balls. So I've got quite a few scars on my chin, and so I do have some temporomandibular dysfunction, and I know that's part of it, because I think I had some ligamentous dysfunction. Now, am I doing an LCL stress to the TMJ? Not typically. I have it, and part of it is because the musculature is so stinking strong. And we'll talk about it later. one of the courses I went to, they were talking about like, what's the strongest muscles in your body? Like, it's your jaw muscles. Like, they are strong little guys. They can go head to head with anybody. So if even if I suspect ligamentous dysfunction, they would have to be under anesthesia and in order to assess that, because there's so much muscular. So functionally, again, I'm not really testing that, but conceptually, I'm wanting to understand that because it could have an effect on their symptoms. Especially, you can imagine, at sleep, right, at night. Or again, the fact that there may be a good relationship of them, again, having some, that's where some isometrics would kick in. So, a lot of people, every TMJ patient gets isometrics, not for me. Because for a lot of patients, I'm trying to get their muscles to turn off. And so it's very rare, honestly, that I give isometrics, unless, again, I think that there may be a ligamentous dysfunction. Does that make sense? Or, again, there's some specificity to the isometrics, not just a general isometrics. So you've got this disc, right, that has this posterior ligamentous structures as well. So this is where, again, different people are going to call it different things. So that's where some people will call it the posterior ligamentous structures. Others will call it the bilaminar zone. And others will call it the posterior capsule, as you can see here. Others are going to call it the retrodiscal tissue, and others call it the stratum. So how's that for consistency in our anatomy? The big thing, as you can see, is that again, you'll see it in some slides, the disc literally is going to slide out of the socket. That's the normal anatomy, but sometimes the disc can actually get stuck outside of the socket. And so the crazy thing about this posterior capsule, it's been described like an accordion, where it has a lot of elasticity, but like anything, if something's overstretched, do you think that's going to be good for it for a long period of time? So that's where there could be some. So I put it in the ligamentous section because that's the way Roccabato characterizes it, and I didn't go into. So again, this guy Roccabato from Chile, you could say, well, not that he's anything in and of himself, but he. The great thing about what he's done is he did a ton of cadaveric studies and a ton of research on patients. He worked at a dental clinic. So a dental school. So he's got all these, dumb students who will do anything. And so he did a lot of crazy research. And then again, he had access to all the cadavers. And so a lot of really helpful understanding of details of anatomy. And so that's where is this posterior structure truly a ligament? The reason that he categorized it as a ligament is because, like a ligament, it's going to keep the joint from completely coming out and staying out. Does that make sense? And again, the same thing, it has an attachment, as you can see on the disc, to provide stability. So there's just more detail on that posterior portion, maintains the articular height. I think this picture gives a good view of, again, this is that posterior laminal area. So then you've got some anterior ligaments, which is the weakest part of the joint. I don't need to go into much detail there. Lateral ligaments, so you do have what's called the temporomandibular ligament itself. Suspends the mandible, restricts backward movement, lateral movement, guides opening. And then the lateral collateral ligament. So just like, again, the knee, you've got a lateral collateral ligament. Maybe strained with condylar hypermobility, and then medial displacement of discal strain ligament. So this would be the one, again, with trauma that you're going to have the most issues. Sphenomandibular ligament suspends the mandible and is caught in terminal opening. So as far as function, resists backward and lateral, or excuse me, the main ligament, the temporomandibular ligament that sustains or suspends the mandible. I'll get into that a little bit later. So these are the ones that, these accessory ligaments here. So again, like why do we have the styloid process? This is part of it, to attach to the stylomandibular ligament. So for the patient who has their mouth open for a long time, let's just say there was trauma with the mouth open, this is the ligament that's could be compromised and or is what's gonna provide stability. So again, is that gonna happen very often, or you're gonna have trauma with the mouth open? No. All right, and then the synovium itself. So this is another one where you're gonna have different camps that are gonna get into great detail on the synovium. There's synovium in different joints, correct? Are you in the habit of palpating all the different aspects and thinking about different aspects of palpation of the synovium? Is that the way that we train you in this fellowship? No. Some camps, and the reason I mention this, are going to try to get real detailed in palpating different aspects of the synovium. I don't do that. I'm not good at, I may just not be as good at it as somebody like Roccabato. But again, I think part of it is he's done the cadaveric studies, and maybe again, there's more credence. I'm saying if you're real tender anywhere around the temporomandibular joint, the synovium, I'm not gonna kind of differentiate if it's the inferior versus the superior synovium versus the posterior versus the lateral. I'm gonna say you probably should ice this thing, and let's have a soft diet, and let's try to get it to calm down, and then I'm gonna teach you how to make your jaw work better. Not that I need to know which part of the synovium is causing their symptoms. Make sense? But some people will get into big detail on this. So let's look at a little video, again, just to conceptualize some of this. I think these videos are helpful.
I almost accepted the dark circles,
Sorry.
sagging skin, and fine lines, until a 15-second routine changed everything.
The temporomandibular joint, the TMJ, is the joint between the lower jawbone, the mandible, and the temporal bone of the skull. The TMJ is responsible for jaw movement and is the most used joint in the body. The TMJ is essentially the articulation between the condyle of the mandible and the mandibular fossa, a socket in the temporal bone. The unique feature of the TMJ is the articular disc, a flexible and elastic cartilage that serves as a cushion between the two bone surfaces. The disc lacks nerve endings and blood vessels in its center, and therefore is insensitive to pain. Anteriorly, it attaches to lateral pterygoid muscle, a muscle of chewing. Posteriorly, it continues as retrodiscal tissue, fully supplied with blood vessels and nerves. The mandible is the only bone that moves when the mouth opens. The first 20 millimeters opening involves only a rotational movement of the condyle within the socket. For the mouth to open wider, the condyle and the disc have to move out of the socket, forward and down the articular eminence, a convex bone surface located anteriorly to the socket. This movement is called translation. The most common disorder of the TMJ is disc displacement, and in most of the cases, the disc is dislocated anteriorly. As the disc moves forward, the retrodiscal tissue is pulled in between the two bones. This can be very painful as this tissue is fully vascular and innervated, unlike the disc. The forward dislocated disc forms an obstacle for the condyle movement when the mouth is opening. In order to fully open the jaw, the condyle has to jump over the back end of the disc and onto its center. This produces a clicking or popping sound. Upon closing, the condyle slides back out of the disc, hence another click or pop. This condition is called disc displacement with reduction. In later stages of disc dislocation, the condyle stays behind the disc all the time, unable to get back onto the disc. The clicking sound disappears, but mouth opening is limited. This is usually the most symptomatic stage. The jaw is said to be locked as it is unable to open wide. At this stage, the condition is called disc displacement without reduction. Fortunately, in majority of the cases, the condition resolves by itself after some time. This is thanks to a process called natural adaptation of the retrodiscal tissue, which after a while becomes scar tissue and can functionally replace the disc. In fact, it becomes so similar to the disc that it is called a pseudodisc.
Adaptability of our bodies. And so clinically I've seen this quite a bit. And it's similar to other dysfunctions where, in the research, as you know, there's certain things where you get surgery versus conservative management. In the 3 to 6 month range, the surgery may be better for a lot of different dysfunctions. But when they do a year-long study, what do they often find? It's the same. And so with these patients, and again we'll get into it, that it can be severe and it can be painful and debilitating. But if you help them to write it out, if they have that anterior disc dislocation without reduction, patiently, gently walk them through it. You're not going to be their superhero and cure it right away, most likely. But as it goes through this process, and it can take up to a year for some of them, but typically their symptoms will calm down and they'll get functional range of motion and do really, really well. But it is that acute stage, it can be rough. And so walking them through that, and we'll talk more details about exactly what that looks like. Any questions on that video though? Helpful to see it? Okay, so we'll jump into the... Oops.
That split of that lateral pterygoid muscle, is
Yes.
the bottom one doing the rotation and then the top one, or is it all kind of?
Yeah, really good question, comment. We're going to jump right in. Good segue. We're jumping right into the muscles. Yeah, so lateral pterygoid is a fascinating muscle, and as you saw, the superior part attaches to the disc, so it is going to have an effect, and then yes, the rotation of the inferior portion. But let's jump into that. So as I mentioned, these muscles of mastication, so they are going to stabilize the TMJ. So as I mentioned, whether you have ligamentous dysfunction, most people over time are going to be fine because of how strong these muscles are. Powerful elevator, right? So this is one of the things I try to emphasize is your muscles, they're working almost all the time. So maybe you say, no, I don't talk a lot. Do you know how many times we swallow in a day? So one research that I was reading said 1,600 times a day. It's just a little subtle. And so you think of a muscle just working a little bit, 1,600 times a day. So if there's just a little skew of the positioning, and then you do that, there could be some irritation over time. And so once again, what I'm trying, because there are people that they feel like their jaw's off, and so stop it. We need to let your jaw relax. It works too much, and people don't get that. Again, if people clench and grind their teeth, and it's like we need, and so it's hard, and I try to be gentle, I don't say something, kind and gentle and gracious with them, but it takes time to get these things to calm down. And that's why I'll use an example. It's like if I'm holding my arm like this all day, you know, I could massage it, I could get an injection, I could even get surgery and replace this. But is it going to get better? And so, you know, again, what do I need to do? I need to allow that to relax. And then all those other things, but then I might still need to massage it to get it to relax and teach it how to move properly, train those muscles not to, but if we're doing this all day, we're not going to have as good, we're not going to get better. And so really, so for those people that clench during the day, to really push hard, some significant, they need to make lifestyle changes. I mean, and that's where you've got your phone, set a reminder every hour that you get a buzzer that goes off, and I've had people that do it, and it's just, and that you get the biggest cure, just getting later. What we'll do next week, treatment time, is it's the tongue at the roof of the mouth. And so you can retrain your body to do different things, because once again, just do it right now. So if you say the word mine, and you put your tongue at the roof of the mouth, and some people I've taught the class, and they're like, I'm doing it, and I'm like, they're doing good. So it's just gentle, let the jaw rest up there. But what happens all of a sudden is the joint gets to relax, and your muscles get to relax. And so that is what we're looking for a majority of our patients. It's simple, but as you know, you can teach people the right things to do, but they have to do it. And so I say it many different ways and many different times, and any analogy or example I can do to try to get it to stick in their head to where they'll do it. So temporalis muscle is one of the major muscles, mandibular elevation. So this is where, again, terminology, and I don't want to go to OCS too much, but sometimes even you're like in a test, what the heck is mandibular elevation? So what is mandibular elevation? It's closing your mouth. Yeah. So just simple, but I put this in there. So this is where understanding, again, anatomy. Okay, temporalis muscle, even the orientation of the fibers. So what does it look like this muscle would do? Close your mouth, right? So it's going to lift. So even that, if you're kind of in just in general, not even just OCS, but you think, okay, so if somebody clenches their teeth, what muscle is going to be active? The temporalis muscle. So what's a potential treatment approach is, one, getting the jaw to relax, tongue to the roof of the mouth, but then there may be some appropriate soft tissue mobilization that we'll get into. I had a patient just last week, I mean, she had the biggest knot I'd ever had, and it was unilateral. She clenched on that, it was like thick. And I was like, is this temporal arteritis? Like, she could die on me? It's like, no, it was just a knot. And she started working it out. It's like, oh, and even me, I could, I'll do manual therapy, but day one, for a lot of my TMJ patients, I try to control myself and just educate a lot and not, but this is a good one. Working that out. So again, we're going to
look into activation for like anterior versus more posterior temporalis, like because of bite. Do you go into that?
I don't personally.
Okay.
Yeah, I mean it could be an option, but I mean that's where that osteokinetic approach. Like I'm looking for wherever I find impairments, I'm treating them and then trying to get their anatomy and positioning. But you could educate me because maybe something I'm not. But we'll do that next week during treatment. So then you also, so what else is going to help with closing? Again, based on anatomy, is the masseter muscle. So there are two aspects of the masseter, the superficial and the deep. So the deep portion is going to stabilize the joint itself. But again, looking at the anatomy and again, even the orientation of the fibers, does that make sense? That would also be active in closing or clenching. And so this is the other one that I spend a lot of time working on and educating patients on. So we'll do it later, but I think you guys were all feeling your temporalis. The temporalis is very thin muscle, and so once again, you can work it in different areas. I almost think of it like, a very thin fillet of fish. It's like, and that's what it is, super thin. The masseter now is going to be much thicker. So the origin is on the zygomatic arch, and then it inserts onto the angle of the mandible. And so if you want to start at your zygomatic arch, and then it's easy to feel this one if you just kind of gently tap your teeth, and then just kind of work down the muscle fibers and just little taps of your teeth, and you'll feel that muscle all the way up. So that superficial portion, and then it is really easy to palpate. The deep portion is what I'll teach you guys how to treat intraorally. And again, can be a big contributing factor for a lot of people with TMD issues. But again, the function elevates the mandible, forceful closure. So this is the muscle that when we chew on an apple, when we, again, and even the fact, chewing on salad, like there's a lot of chewing that's happening. Whatever it is, that's the muscle that is. So trivia question that, next time you're at a party, what's the strongest little muscle in your body?
Lateral
It's the
pterygoid.
masseter. It packs a punch. So then you also have the medial pterygoid. So this is going to be on the inside of your mandible. So it's fascinating because it's just a mirror basically. So some people call it the mandible sandwich, where you have the masseter on the outside of the mandible. On the inside of the mandible, you have the medial pterygoid. And so both of those are going to also function, again, with opening. It also has a function on, and this is where it's fascinating, unilaterally deviates to the opposite side. And so the way things function, again, I'll show another video where you can see the muscles working together as you chew, or as we call it lateral protrusion, as you move your jaw side to side. And then the lateral pterygoid, so this is the one that you guys saw earlier. This doesn't show the belly's kind of broken up, the superior versus inferior belly as much, but it would make sense that it's going to control that horizontal plane movement. As we talked about, the superior stabilizes the disc, and then the inferior belly is going to be the main mover of protrusion. Does that make sense? Again, so you think about anatomy, what's the orientation of the lateral pterygoid? So that's where, again, I know these names can be hard, but whatever, mnemonic, or again, mandible sandwich. So you got medial pterygoid, you got masseter, you got mandible, so you're kind of your three M's, and medial pterygoid, right, are all kind of together. Does that make sense? And they're all going to help with closing. But the medial pterygoid, because it's on the medial side, is also going to help, and we'll get into that later, with the lateral protrusion to the opposite side. And then the lateral pterygoid, it's kind of the funky one, kind of all by itself, that it's going to be the one that's going to have a lateral movement, right? The orientation is kind of more this way, so it's going to help with protrusion. Make sense? And then with that, it's going to have a big role to play in grinding. So if you're here, because the fibers are going to have kind of a forward, but then also a lateral as well, orientation. So then the other muscles to be aware of, okay, what muscles then open our mouth? And this is one that I emphasize with my patients as well, is what muscles open my mouth are actually the deep muscles in my neck. Okay, so think about it. If you have some tightness, like I do on the right side of your neck, and you open your mouth, could it be that if it's so tight on that right side that it can pull your jaw to the right. And you can imagine with patients, I'm like, oh, all of a sudden, and maybe for you guys too, right? Because these are the muscles that open your jaw. And again, I don't think we think about that very much, is, wait, it's my neck muscles. Again, it's the deep ones, and we forget about these. We're often thinking about more of the superficial neck muscles, but these deep ones are active as well. Cyst and jaw opening. So you got all these different hyoids, sternothyroid, and they're pretty big muscles. Again, they're just deeper. So opening, pretty easy. Anything that's got a hyoid, thyroid, giant, but anything with an oid in it, you're gonna think opening. And then for some reason the digastric, I don't know why.
Just a question.
Yeah.
So if a person is a clencher, like at nighttime, and they wake up with soreness in this area,
Yes.
those muscles are not necessarily working.
Right.
It's up here, right?
Yes.
It's creating the tension.
Yes.
So why? What's like I'm trying to.
Yeah.
Why
no,
would
it's
they
a really
have pain
good,
here?
It's a really good question.
Is that mainly more in neck, high cervical spine then?
It-
Because this person also has chronic
Right,
neck.
right. The only thing that comes to my mind is in regards to just the way our body will kind of compensate. So it's almost like it could be that their body reflexively, their other muscles are trying to work because it's clenching so much, if that makes sense. And so the hyoid muscles are trying to work reflexively. That is the only thing that comes to my mind. The other thing is just positionally. Yeah, are
Right.
they getting? So that's one concept. The other would be, again, if they're positionally putting those muscles on tension, and that's what I find a lot is people will sleep, even if they're on their side, and this is where it's fascinating. You think of even like, what's the first steps of CPR? Tilt the chin. So people who have trouble breathing at night, a lot of times they'll reflexively go into this position, and then again, what's on tension. So that's one that I'll spend a lot of time is really educating people. So, you know, do you have sinus issues?
Yes.
Like that's a time where it could be even seasonally. Okay, why is it that your TMJ is flared up this time? Well, it could be stress. It could be that your allergies are flared up, and you're not breathing, or when you have a cold, right? You have a combination of cold, your immune system, right? Your lymph nodes are swollen. I have some people that's when their TMJ flares up. So different things can contribute. It's a good question. Sorry, my great answer. So then, just getting into the muscular activity. So just once again, so what is doing opening? Well, its primary, is these. So the lateral. So this is the interesting one because when you have. So this goes back to your comment, Aaron. Remember that the the superior pterygoid attaches onto the disc, the superior belly of the lateral pterygoid. So when we open, and we'll get into the arthrokinematics in just a moment, there's initially should be a rotation motion. So the initial mover is actually the lateral pterygoid because there's that rotation that's happening through the lateral pterygoid. So the primary initial mover of opening is the lateral pterygoid. Does that make sense? Because that disc is going to be moving. And then now we have another movement. So there's translation and there's rotation that are happening. So you're getting the lateral pterygoid that's helping. And so, I went back and forth if I should change this because it was a more recent article that I read that talked about the lateral pterygoid being the primary mover. And again, I think that they're looking at that initial movement. So it's really a combination of both. Okay, So, closing, which muscles are doing that?
Oh.
Medial pterygoid and somebody said master, yeah. So you got your three main muscles that are doing that. And then protrusion, do you guys remember which muscle is doing that? Say it loud, confident. Lateral pterygoid. Good. Good. And then the secondary, and then this is where the orientation of fibers is going to have, so there's a little bit of work through the medial pterygoid and the masseter just because of the orientation of the fibers, but it is primarily the lateral pterygoid that's doing that. And then how about retrusion? We actually didn't go over this too much. Any thoughts? Nice, good job. Yeah, so temporalis because of the orientation of the fibers. Okay, so if you can think about that upward elevation. So this is where some people with braces sometimes can have their temporalis will be a little bit more irritated just because it's like their muscles are fighting against each other. So then lateral excursion, this is the one that is a combination of movements, okay? And so a lot of times we don't really think of lateral excursion, but as we get into it, it's gonna be a really important objective measure for you guys to start looking at because there's repercussion or implications in regards to the musculature, but then also what's happening at the joint itself. So it's a little bit confusing, but the more if you get it and understand again the anatomy, then you'll understand what's happening. So you're going to have, so let's say we're doing left lateral excursion, okay? So you're going to have your left temporalis. Does that make sense? That's going to help with that. You're going to have, and this is where it's kind of confusing, that the lateral pterygoid is actually going to help with both. Okay, so both sides, and then the right medial pterygoid is going to help with that. And again, I'll have a video that will help clarify that a little bit. So this, I think this guy kind of helps a little bit, is you see that. So the temporalis, so we're going to the left, the temporalis is helping. We got the lateral pterygoid, the medial pterygoid, does that make sense? But then we also have the lateral pterygoid, the superior, or the inferior belly, that's helping on that side. So superior belly of lateral pterygoid there, medial pterygoid, inferior belly of the lateral pterygoid, and then even the masseter on this side. In some regards, I didn't emphasize the masseter because usually I don't see that as much. So another view of that. So as you have that lateral excursion, there's going to be a movement of the joint there. Okay, so the reason I have this, so when you're checking left lateral excursion, what you're actually checking is the joint space, the joint movement of the opposite side. Okay, so if I'm checking left lateral excursion and they're limited, then that's typically going to be because there's a dysfunction on the joint on the opposite side. Now if I go to left lateral excursion and it hurts on the left, say that again?
That one is it's the dysfunction.
Oh, it could be that it's more muscular.
Mm.
So that's going to be versus it's going to be the joint on the opposite side. Yeah. So left lateral excursion. If it's limited, it's going to be the right side of the joint that's going to be implicated, and you can see. So if I'm trying to go to the left and it's stuck up here, does that make sense? It's not going to move the way that it should. So the arthrokinematics of the joint, there's three typical phases. Okay, and so the first phase is the rotational motion. And so this is I talked about the inferior and superior joint spaces of the joint. That rotation happens in that inferior joint space. So once again, we've got the disc that sits in between, And so the first stage is rotation in that inferior joint space, and that's what should happen. With a lot of patients, though, that doesn't happen. What happens first for them is translation. And that translation happens at that superior joint space. And one of the reasons this happens is because a lot of people have a tendency to clench and grind. Okay, so when you're clenching and grinding your teeth, what do you think you're getting? Rotation in your joint or translation in your joint? Translation, exactly. And so what your body is used to doing is translating. So when you start opening your jaw, what's the default going to be? Is it's going to translate first. Okay? So then if your jaw's translating first, it's more likely to hit that condylar ridge that could contribute to a early click or a later click. But that's where what we want is to reestablish rotation in that inferior joint space. And as we talked about that bucket handle, there's the opposite movement of the disc and the joint, the condyle initially. So then the second phase is when translation should begin. Okay, so you got the disc and condyle begin to move together. And then the terminal phase, condyle translates downward and forward on the articular eminence. Okay, and so that's where the joint starts kind of coming, in essence, out a little bit is the way we describe, just to make it, again, simple for patients to understand. So lateral translation of condyles also occurs in the lateral half of opening. And so that's what you all felt is when you open, if you feel the condyle popping out early, it's because translation is happening early, which what should happen is rotation should happen early. But even with a normal, that translation is going to happen, right? Not at the first stage, but at the second stage. So you'll feel some of that at your condyle itself. So that's, again, when I'm assessing patients, I'm looking at not only just like anything, not only the quality of the motion, the range of the motion, but I'm palpating their condyle to see when that translation's happening. If I feel that condyle popping out right away, I know there's a translation issue. And often it's an early translation issue. So then I need to teach them how their jaw needs to rotate first. Is that clear?
Question, so if you're like, they're opening, you're feeling it go down, then it comes out, then that's more the proper kinematics versus if it pops out right away, that's, okay.
Yep.
So it should be like, okay.
Yep, exactly. So for most people, that tongue at the roof of the mouth opening, what that does, and this is one of the treatment approaches, is it teaches pure rotation. And so if you put your tongue at the roof of your mouth and open, and that feels different than opening without your tongue at the roof of the mouth, then you're likely getting some early translation. And so then what this tongue at the roof of the mouth exercise becomes is a neuro re-education exercise. And so that's teaching. So how often should you do a neuro re-education exercise?
That's it. Rocapolto says six times a day, right?
Yeah, exactly. So he has the 6, yeah. I say every hour do it, and most people, and I'll kind of use this 6. But yeah, the idea of it's about developing coordination with the muscles. And then this is where, I know a lot of you have gone through P&F. This is where it's fun that you can even start then so I mentioned I'm not doing a lot of isometric resistive training, but you can do some P&F at the TMJ. Because again, it's neuro re-education at this point. For a lot of people, their default is because their jaw has been functioning abnormally for so long, is that it's going to want to deviate or deflect to, we'll get into this, but it could be the side of hypomobility, or it could be there's hypermobility, so it's just a motor control issue. And so you can try to retrain them. So you might do some rhythmic stabilization, I forget all the different P&F terms, I just do it. That's where it can be fun in your treatment approach. In understanding, again, what I'm trying to do is I'm trying to retrain. So now I'm gonna do, it could be some guided movement, some resistive movement to try to get them to stay in that neutral position. So then with protrusion, there's a symmetrical translation of both the condyles and the disc on the articular eminence, and that's going to happen in that superior joint space. Does that make sense? So protrusion is straight translation. Where does translation happen? Inferior joint space or superior joint space? So translation is happening at the superior, right? So that's where that's going to happen. And so that's where, again, I was kind of punking Rockabato's camp for the synovial mapping. That's where they'll be like, it's that superior joint space where a lot of times the synovium is going to be inflamed or irritated because there's too much activity happening at that superior joint space. So let's go and watch another video.
Tab type 2, you'll love the sugar balancing trick in this video. Most people don't know that unbalanced blood.
This is just a 2.5 minute video. So they're showing the arthrokinematics. What I like about this is it shows, oh shoot, sorry. I like it, I can see it, but you can't. You can see the arthrokinematics in just a second. So he's going into right lateral protrusion right now. So you can see the musculature. And he's going to be able to, when you get to the posterior view here in just a second, you'll be able to see a little bit more. So we're going into right lateral protrusion. And so we got the, let's get to a different view. So here we go. Let's ensure. So right lateral protrusion. So we've got the medial pterygoid. He's not really showing it very much. We've got the temporalis on the opposite side. And here you can see the pterygoid here is working. The other piece is not only the musculature, but see what's happening within the joints. The posterior view is the one that I like the best. We'll go there in just a second. So notice what's happening at the joint here as nothing happening in this joint. Can you see how that? So that's where as you go into right, this is the main thing I wanted to emphasize here, as you go into right lateral protrusion, if there's a capsular restriction here, could you see how that wouldn't move? So that's the one that's, again, I think really valuable to see it here now clearly, right lateral protrusion, there's going to be more relative movement on that left joint surface. So bottom line for this, you want to remember this, anytime you're assessing lateral protrusion to one side, you're assessing the joint on the opposite side. Okay, make sense?
This video was sponsored by Ken Hub.
Yeah, so this is what we saw. So lateral extrusion, chewing motion is what we just viewed. Condyle disc pulled forward, downward medially. So a little bit of rotation, and again, that's going to occur in that superior joint space. And we saw that, right, where the condyle pull, it was pulled forward, downward, and then immediately as that motion was happening. And so then you think about, again, within the joint, if that's not happening, now you get into what most of us know from PT school, what's one of the joint mobilizations that we often do for the TMJ. It's going to be a distraction, right? And so then you could get a little bit more specific, though, knowing the anatomy. So I'm going to pull, I could pull the joint kind of down. I could pull it medially, right? I could pull it anteriorly. So you're getting just like, again, a shoulder mobilization. You know, you could just do a straight AP, PA, or I could do some coupled motion. I could do a little distraction with it. So the same thing, that as you get into your joint mobilization, it's not, I'm thinking, okay, what am I feeling? Or what if I add a little bit of more of a medial or lateral, or again, I can get a little rotational, just, oh, now that's my symptom. So it again, understanding this, that it's not just a simple pull down is kind of what I'm getting at when you do your joint mobilization. Make sense? All right. So biomechanics, you guys doing okay? Potty break or go a little bit longer? Okay. Yeah, sorry, today's just lecture heavy, so please forgive me. Next time we'll get into so I'll be with you guys next Tuesday. It'll be less lecture, a lot more hands-on. We'll do labs. So on that note, I mentioned, just so I don't forget, if you guys could help me out and make sure that we have gloves next Tuesday, and
Tongue depressors.
tongue depressors. I think those are the main things that we need. If you, actually a couple of small goniometers would be good, because we'll look at how to measure the jaw itself. You guys probably did that just as a reminder, and I'll show you some simple tricks on how to do that.
We have the paper, like,
Yeah.
oh, but do you want those or?
If you have them, you can bring them for sure. Yeah, that way we can, I don't typically use them just because I don't have them, but if you guys have them here, yeah, then you know where they're at. You can show everybody else. That'd be great. All right, so I mentioned this earlier, just thinking, so we started very, again, myopic, very detailed joint anatomy, but now we're going to kind of branch out a little bit, because it's not just the local joint itself. And so just as the movement of the glenohumeral joint, right, is determined by the position of the thorax and scapula, as well as the mobility and stability, right, of the AC and SC joints, it's the same thing with the TMJ. As you can imagine, is if I'm getting into different positions, that can affect. So for example, go ahead and just go ahead and tap your teeth together right now. And as you tap your teeth, which teeth do you feel hitting most? It may be a little bit different for all of you. More anterior, right? More posterior, maybe more on one side more than the other. Now, tilt your head back and tap. Do you feel it a little bit different?
Mm-hmm.
Put your head all the way down. Tap your teeth. Do you feel a little bit different?
Mm-hmm.
So does head positioning affect the TMJ? Yeah. So this is where, again, it's a difference of philosophy, where a dentist or orthodontist, all they're going to be looking at is occlusal contact, right? And so it is that. So we cannot change occlusion. So this is where dental world, again, knowing it, and versus PT world. We can't, so occlusion is now kind of bite down. Now hold your bite and put your head up. Hold your bite, put your head down. Does that change?
Mm-hmm.
No, so that's occlusion. What we can affect is first occlusal contact. Okay, so that's the difference. And so that's where they'd be like, well, you can't affect occlusion. I'm like, no, you're right. But with most of our patients with function, is it their occlusion or that first occlusal contact that we're dealing with them clenching and grinding their teeth and biting and chewing, right? A lot of times it's that occlusal contact. And so that's what we can affect through the positioning of the head and neck, and even, again, the muscular components that are going on.
Side note, I hate going to the dentist and they have to do, you know, whatever they have to do, and they're like, test your bite, and I'm always like lying down, like, I need to move.
Exactly. It does change, yes. Okay. So that's where it is a compound joint made up of 3 or more surfaces and planes of movement, not just a hinge joint, right? And so this is getting, again, a little more narrow back to the TMJ itself. So during the opening, this is where it's not just, right, we talked about, okay, there should be first 12 millimeters of opening. Should it be rotation or translation? Rotation. So we should get pure rotation. Then what starts happening is we get some translation, right? And then we continue with that motion. So rotation, some translation. So within the joint, rotation, some translation, and it's going to look like this. Again, the description that I'll give to my patients is, again, distribution, rotation, translation. This is what we're looking for. But is it just one plane? No, we felt that, right? There's some lateral excursion that's also going to happen. And again, some protrusion. That's what we talked about, that translation or protrusion that's also happening. So we already talked about this, lateral excursion. We're looking at the right TMJ. Opening is often, though, asymmetrical but still functional, like a lumbar joint dysfunction. So you could have a full range of motion, right? But if you're tight on one side, you could have some deviation to that same side. So again, so another way to say it is, as I'm opening, if I'm which side am I going to deviate to in regards to the side that's tight?
So the tighter side.
So you're actually going to deviate towards the side that's tighter. Okay, so does that make sense?
Or do
Yeah.
you call that one the C deflection? Or do you kind of change? Yeah.
Yeah,
As
so
far as
it could be
terminology?
either. So it could be, there could be just a true deviation where it doesn't come back. So a C deflection is where it actually comes all the way back. Some people, as they open, it's just a pure deviation and it's just consistent. There's some that will have an S curve where it's, and often that's going to be, and we'll get into that a little later, where that's more they need more neuro re-education. So, yeah. So then that's where, again, if we want to increase opening, we don't just treat opening, we may need to treat, again, protrusion and lateral excursion as well, and we'll talk about treatment techniques for that. So again, boning wise, it's not stable, so that's where we have these two joints. One way I heard it described is like, you know, it's almost like if we didn't have the disc, it'd be like two soda cans rubbing against each other. It's not going to be very stable, right? So you put an articular disc in between, and that adds stability. So we hit this hard already. Inferior is rotation, superior is translation. So apposition, so that again, that's that idea of the saddle on the horse, right? So when there's apposition, when things come together, so that's where, as that translation happens first, the disc and the condyle seat together. Does that make sense? So there's going to be that seating together as that rotation happens, then they translate together. Because if that rotation doesn't happen, then you have a sloppy disc. And so then that disc can slide in and out more easily. Do we want a disc that slides out? We saw that initial video. No, if that disc is sliding out. So again, I'm hitting this hard because the exercises are simple, just to be honest, some of them. But you gotta own it. You gotta actually believe it, and then you have to push it hard, because everybody's looking for novel. Everybody's looking for what's the new trick, the new fad. It's like, a lot of it's fundamentals. You know this with a lot of things, but people have to do the fundamentals. And we have to push the fundamentals. And once again, I'm hoping you understand why these fundamentals are so key. Does it make sense? That's those soda cans. They're slippery, but if the disc is there, but that disc is going to slide if that rotation doesn't happen first. That rotation, once again, sets that disc in opposition, confirms it. Make sense? Okay. And a lot of times we think, well, we don't want things to go together, right? So that's where, but in this case, as that disc seats, then they, again, now together they can slide, not the disc sliding forward in front of it. Okay? If there's too much distance between the two convex structures, the disc loses stability. It can be displaced. Clear? So the resting position equals the correct posture. We worked on this, so everybody go and do it right now. What's the resting position? Where should your tongue be? Roof of your mouth. So I want all of you guys to try to practice this. Let's see how long you can do it. We'll have a party prize for whoever keeps their tongue up there the longest. So as you do that, notice that your teeth are slightly apart. Okay, and I'm going to be looking at you guys. So don't be surprised if I start staring at you. Tongues placed at the palate. So different terms. So this is, dentists will use some of these ideas and terms. That's where this is where it becomes a little harder, because there's dental terminology, there's PT terminology that gets intermingled. So they're going to talk about centric relation, the most stable position, which is the tongue, once again, at the roof of the mouth. It's the same thing. And then centric occlusion is that teeth are at maximal intercupsation. So that would be, again, occlusion, maximum occlusion. That's what dentists and orthodontists are all about, is when there's occlusion. So another phenomenon that I think is a relationship, you may remember this from back in PT school, that there's this 4-to-1-to-1 relationship in regards to the amount of opening. So normal biomechanics is that you would get 40 millimeters of opening as you open your jaw. So as I open, approximately 40. The average is 30 to 50 is kind of the norm. And then with that, you should have at least 10 millimeters of protrusion, and then 10 millimeter of lateral occlusion side to side. Now they say this relationship because there's people that potentially have had anterior dislocation without reduction, that little video that we saw, then that turns into that pseudodisc. Some people, I'm shocked, they get their full motion back. And again, seeing that video is, I think, helpful. It's like just because they've gotten a new disc, basically. This pseudodisc has happened and their function is great. Others, that pseudodisc isn't going to form quite as well, and so they're still going to have, so they may have 30 millimeters of opening, and that's very functional for them. So would I expect them to have 10 millimeters of lateral extrusion both sides, or around 6 or 7? You see where I'm coming from? So that's that 4 or somebody who has 50 millimeters of opening, then you would expect them to have more protrusion and more lateral extrusion bilaterally. And if they don't, then that could be a sign of dysfunction for them as an individual. All right, so palpate condyles, as you can see, tongue at the roof of the mouth. We already did this. Tongue rest position. Fully protrude and try to open. Doesn't work quite so well, right? Compression occurs. Other biomechanical considerations, your lips. Normal resting is teeth slightly separated, but lips closed. All right, so this is another one. For some people who have a habit of clenching, they're overworking even at their lips. Okay, so not everybody has to do this, but I want you guys to try for the next couple minutes. So tongue at the roof of the mouth once again, and allow the lips to be separate as well. There you go. A little more, Tina. There you go. Those lips relax. Good, Aaron. Ryan's got it. Try a little more. There you go. Tongue at the roof. It feels weird. Keep going. Keep trying. So it's awkward for some people. It might feel like you have a goofy smile. It may feel like a fly is gonna fly into your mouth, literally, because we may be subconscious about our teeth. There's a lot of different things that could be contributing, but letting that extra little step of even letting your lips relax is one other way to allow the jaw to relax. Because I got a lot of people, they're like, yeah, that's my default. My tongue's at the roof of my mouth and I'm looking at them. Does that make sense?
Yeah.
So it's not to that extreme.
I just felt it slowly go
You
wider.
start opening more. Yeah, your body's like, I'm smiling as you relax. I like this. And I see, I mean, some people, because I'll often introduce this early in my assessment of my TMJ patients, and then I'll challenge them, and then I'll remind them. And some of them, by the end of my session, they're like, my jaw feels so relaxed. It hasn't been this way for years. And obviously that's rewarding, right? That you're to be able to help people in that way. And it's not everybody. Some people are like, you're a quack. This doesn't seem like what you're talking about.
Do you feel like lip fillers change this ability to relax? I mean, I feel like that has to a little bit, right?
Say that again?
Like, what about lip fillers? I feel like that has to change their.
I don't even know what lip fillers
Women
are.
Control-
that do
like they
prosthetic,
inject,
sorry.
Sorry, yeah, like they're injecting silicone.
want
or-
bigger
Oh,
lips.
yes,
Yeah.
Angelina Jolie.
Yeah.
Yeah.
So then they have this new
Yeah, I could.
mouth.
Sure.
Right? Because that has to change your muscle function. I
Right,
think,
I'm
right?
sure.
Yeah.
Yeah, I mean, the one I talk about is tongue rings. Like that one for sure, because
Yeah.
people they tend to play with it. It's just an extra obstacle. So yeah, I mean, all the cosmetic surgeries that people are having.
But you don't go as far as asking like patients, oh, were you breastfed or were you bottle fed? Like, because that also changes the development of the muscles, right?
I don't go that far. So good comment.
When I had my daughter, I was like, okay.
Yeah. I mean, the one that I do, I mean, even for my kids and for you guys, if you're gonna have kids at some point or do the putting the pacifier in the mouth.
Yeah,
No
we
bueno.
did not do that.
Yeah, exactly. Because you're artificially forming a palate
Yeah.
in those developmental stages. That's not good. So, and then this lip one is kind of an interesting one. Is the upper lip should cover 3/4 of the teeth. And so this idea that could cause abnormal perioral master muscle activity because the upper lip, because it's so short, again, it's a subconscious thing that a lot of people will do, where they'll use the masseter to try to cover it. So Rockabato had a case that he showed, and it, cute little girl, and she just had a super short little upper lip. And so what he did is got like gauze that rolled up, and part of her exercise prescription was have the gauze, and then to do mobilization. So the gauze was in there all the time, and so she was in those formative years where they were able to stretch out her upper lip and kind of loosen that up to where then her musculature didn't have to compensate for that short upper lip. So if you see pediatric kid, which I see some of them, and you notice, again, some of these anatomical features, it could be something to address. Tongue a little bit more, functionally helps with swallowing. As we talked about, essential to train. And then this is one where I will assess people's tongues as well, because there's some people that have humongous tongues, and having that could be a contributing factor because they tend to bite on their tongue more. And so, but it's the same strategy is for them, it's still putting the tongue at the roof of the mouth to get it out of the way. But again, if they have such a big tongue that they might bite on it and it could cause irritation. And so what you're looking for is this malocclusion. So again, their bites off, scalloping. What you'll see is they might have actually ridges on the side of their tongue that you'll see. We'll talk about another one that we'll look at when we do lab next week, where you're looking on the cheek to see if there's bite marks on the cheek itself. And some people will say, oh yeah, I don't clench my teeth, and I look at them and I'm like, actually you do. So you do need to work on this. Or again, some people, I've actually taken pictures of it just so they can see it. Because a lot of time, I mean, these days I don't have a flashlight. I'll use my phone as my flashlight, and then I won't take a picture on my phone. I'll say, hey, can I use your phone to take a picture? I don't know if you guys do that. I mean, I did it yesterday with a guy with a significant length discrepancy, and so I asked him if I could have his phone and took a picture of it, and he was just so tight. Like I didn't have time to do true measurement of is it a true or functional. I'm pretty sure most of it's functional, so I wasn't getting the tape measure. But to read, like, this is why you need to do your stretching, because this isn't me just doing some chiropractic voodoo of your legs are off. Like, your legs are off, and this is part of why you're hurting, and so you got to stretch. So sometimes, again, that biofeedback of using their own phones to take pictures can be really helpful if you haven't done that. Get permission, obviously, but then it's theirs. Influence of mastication, models bones and soft tissues. This is what you were getting at, Manuela, these early things that we're modeling what our tissue is going to be at an early age. So overjet, increased activity of the masseter muscle and anterior temporalis. Dental equilibrium can change by small change in force over a prolonged period of time. So orthodontics can be an issue. So this idea, again, there's some people that have failed orthodontia, and so is it that the orthodontist did a terrible job, or is it that 13-year-old's been sitting like this and they wonder why the orthodontia isn't working? And so, a couple of, I took one course and it was private practice, and they are making bank on TMJ patients because they coupled with local orthodontists. And so it was almost pretty much like everybody who got orthodontia gets VT. And so do you think that the orthodontist is going to be happier if their patients get out of orthodontia quicker? The patient's going to be happy. So let's promote an environment where parents are going to be happier, right? If their kids have better posture and are healthier and not complaining of headaches. So if you, again, this world, you saw how much the chronic pain population, and again, I might get into it, but there's another study that I saw with preventing, it's all about early treatment approaches to prevent chronicity. So if we can get to these people early. So the idea of overbite versus, the only reason I bring this up is if you read or the dentist notes, sometimes they'll talk about, so there's overbite, which is your jaw anterior, versus overjet, which is it coming, your teeth coming over the top. Does that make sense? So the overbite versus overjet. It's not something that I think is a really big thing that we need to overemphasize, but you're just wondering what the descriptions are. So again, overbite, your jaw coming forward; overjet, your teeth coming over the top more. So postural considerations: alignment of teeth and shape of face can be altered by posture, muscle activity, and breathing. I mentioned this a little bit. Upper respiratory infections can cause changes in posture relationship between cranium, mandible, and cervical spine. So all of this relationship that, again, our bodies are being modeled in these early stages. And so that's where we have a vital role. Again, you see it, we see pediatric kids. And this is where it's crazy. I've been, like I said, a PT over 20 years now, and you see again, you guys have been to AOMT and APTA, you've seen some stuff, but there was a season where it was like, posture is no big deal. It's like, oh, don't worry about posture. There's no, like, developmentally, posture is a big deal. And so to be able to, again, you see that slouchy kid. I was telling Ryan, I'm thankful for Michael Bang. He would always get on me for my posture when I was in the fellowship, and now I'm paying it forward. I should. But it has an effect. So this was I love this study. So this was outside of Rockabado's camp, even precursors for TMD, earlier walking age. Why do you think that's precursor?
Cervical posture.
I remember my daughter, and it is great. She walked at 9 months. I was like, yes, she's a champ. She's struggled with upper cervical dysfunction and postural dysfunction her whole life. And I'll be honest, there's times I'm the worst PT ever. I can't even treat my 8-year-old daughter because she would wake up with horrible headaches, like horrible. And it was all upper cervical, and I'm trying to get her posture. But when you skip some developmental stages, it's an uphill battle. And so all my other kids, I was always about prone, right? We know that. But then it was like once we got but she hardly crawled at all. She just kind of skipped that stage. And so to develop that early strength is super important. The increased interscapular angle, rhomboid weakness, isn't it crazy? So these, anything about the jaw? Anything about your bite? Or are there other things that are predisposing? So getting into the craniocervical relationship, change in mandibular position. Change in mandibular position can affect cervical posture. Fascinating, huh? So there is a relationship between your positioning. So if you're clenching your teeth all day, there can be a tendency because of the clenching that for patients, they may tend to get into poor position. So that's, and I'm, even as the TMJ guy, do I ask all my cervical patients, do you clench your teeth? No. But do I observe them? And I'm like, are you clenching your teeth? So it could be something to consider because that could have an effect. And then, yes, for sure, there's a lot of evidence out there that forward head can affect the TMJ. So this is one that I think is really helpful to understand muscularly. So I mentioned, for me, when I took a course, I was like, wow, it's amazing, it makes sense. It's the anatomy. So you think about, we talked about what muscles open our mouth. It's all about the hyoids, the digastric. So if we get into poor posture, what am I doing to all those hyoid and digastric muscles? I'm putting them on what? Stretch. Do our muscles like to stay in stretch? No. So what are your muscles going to try to do? To get you out of that stretch position. But what's the easiest way for it to do that? Is it easier for us to do this? So then what can happen reflexively is your jaw tries to open. This is reflexively. And this is where it's cool. Some of these studies, they've actually seen it, like the EMG, what the muscles are doing. So you're here, your muscles are going to try to open to get you off of slack. Make sense? Do you want to, though, walk around with your mouth open all day? So what's your masseter muscle going to do? Close. But this is trying to open. So what's happening with your muscles? Fighting. Does that make sense? And so you wonder why there's so much tension here, tension here, is these muscles are fighting against each other. Then now add another combination to where, what if my head's kind of tilted a little bit to the side, a little bit rotated, and now I start opening my mouth and I'm here. What are these muscles going to do? They're going to try to pull to get you, because our body, you know this, it's always trying to fight to get into a neutral position, isn't it? And so that's where our head will kind of tilt, and lower cervical might tilt, and upper cervical is going to tilt the other way to try to get us in a neutral position. And so that can happen at the TMJ as well, is the musculature. And so then once again, you know, it's like, well, all my pain's on this side, and then you feel the other side, it's like, ooh, that's pretty locked up as well. Or again, why do I have bilateral symptoms? It's because this tug of war is happening. So does that kind of make it a little bit more clear? This is why we need to get things in neutral position so that all of a sudden the jaw can start working in a better way. And why this is not a quick fix for a lot of people, right? And that's where it's difficult, because everybody wants a quick fix. Now there are some that, yeah, they get better really quickly, I'm thankful, but those are the people where it's more acute, and they haven't had long-term postural issues potentially, so different things that be contributing. Any questions on that with posture? Yeah, go ahead.
Yeah, I mean, and then for some patients that have most of their pain happening at night,
Yes.
and they're already with plinth, with the mouth guard, and like, okay, education on position for sleeping for the cervical spine, right?
Yeah.
The right support and being neutral. Then like, what else do you explore?
Yeah, really. So we'll get into some of that
We'll do
next
that
week.
next
But I mean, the one piece that I like to really emphasize too is with clenching, because a lot of people, there's the sleep positioning with the head and neck. There's the one piece that a lot of people don't recognize is that upper cervical extension, that can happen in a lot of different positions. I mean,
Yeah.
I noticed in my own life that I was starting to get some headaches, and what I found is I would lay on my side, but I would tend to
Yeah.
go here. And so one course that they just talked about pulling because we feel better. And so then, because I naturally breathe through my mouth at night, so I do get some of that upper cervical extension. So biasing myself in a little more lower cervical flexion, so that even if I do go into some extension, that there's a little more room for error. So that's one. And then the other thing is, clenching, is that something for most people that's a subconscious thing or a conscious thing? Subconscious. So what I'm trying to do with that tongue at the roof of the mouth exercise is that it's a conscious activity initially, but my goal is that they do that so much that becomes subconscious and becomes their default. So if they have a new default subconscious activity during the day, then what could happen at night?
Translates over.
Default, yeah.
A new subconscious default activity at night. And so that's what I'm looking for. And I've had it that there's some patients that have been so dependent on night guards, but some people a night guard doesn't, because I've had so many people, they clench through their night guard.
Yeah.
And so the night guard is actually not being effective for them. And so to get rid of that night guard and actually let's get better positioning, and then let's just bust your tail all throughout the day to, again, try to neuromodulation. We believe in it, right? We know it can happen, so it can happen in this way too. Make sense? Good. So you're commenting about the S curve and the C curve. So dysfunctional movement, and we'll do 2 more slides and then we'll take another break. So S curve, anterior subluxation of the disc off the condyle. Okay, do we want that disc to sublux anteriorly? No, we don't want that to happen. So as that happens, what the jaw often is going to do is it's going to kind of try to like get out of the way. Does that make sense? So when that disc comes anteriorly, you're going to get that click. Your jaw can want to kind of get around that ridge. Does that make sense? So it's going to kind of slide around and then slide back in. So a lot of people, you'll see this S curve, rolling phase. It may occur, but at anterior translation, it's initially blocked. So again, these are kind of some details as far as different things that are happening. But that S curve can happen. So where do you go, right? You go back to your foundational principles, which is we want rotation first. We want rotation first. And then we want to train them how their body is to properly work. So again, this can be, you can see early disc. So often this is we'll get into these categories. This is often gonna be that anterior dislocation with reduction, is this S curve. But often what you need to do is they need more neuro re-education, because a lot of these people have full range. So again, the rotation and then training them how to move properly. It may not be a capsular issue is what I'm getting at, okay? Whereas a C curve, you're often gonna see this is more of a capsular dysfunction, to where they're gonna deviate towards the side of what? Of dysfunction, exactly. So they're gonna deviate towards the sides, and then once they've deviated, then there can be, again, this sliding back into the proper position. So it deviates towards the involved side, to the end range, but then it deviates back at the end of elevation. And so, again, you think about mechanics, what's happening is it's getting out of the way, and then once it kind of slides back in, and then you may see that as they close, the same thing, that deviation's happening again. So common things that you'll see. So let's take a break, and we'll start out with the yoink video.